Okay, the last sort of mini discussion we're going to have, which is the last of the day, and we'll finish on time for sure, is how to monitor the RED implementation and outcomes. And this is important for you to know how well you're doing and to know how well you're both implementing in terms of process measures and how well you're actually achieving the goal that you set out in terms of 30, 60, or 90-day readmission rates, if that's what it is. So monitoring the re-engineered discharge is important to ensure proper implementation, to continue adapting and optimizing transitions, to be sure that some of the choices that you've made can be adapted and changed depending on some of the results that you find. You will likely need interdisciplinary leadership, and sometimes researchers and statisticians and research assistants and others may be necessary to both collect and analyze the data. And at times, personnel with additional areas of expertise will be needed to augment the core evaluation team to ensure success. So we're going to go through the list of components and talk about what are some of the things that you might want to use as core metrics as you go through the process of setting up of the discharge program, knowing that you're never going to measure all these metrics at the same time, that it might be worth the implementation team going through the various core metrics. Those, like there are so many that you're doing so well now, you may not want to measure so frequently or so much in detail, but those that you identify as potential things that you need to improve on are the areas that you might want to spend your time in terms of data collection. So in terms of monitoring, making an appointment for the clinician, a follow-up appointment and patient discharge testing, some metrics that could be measured are, number one is the percent of PCP appointments that are scheduled in the hospital. How many people go home with an appointment and how many people go home without an appointment? And you can set as an implementation team what you think the goal number is. Is that 80%, 90%, 100%? And then measure it. Once you achieve whatever the goal is, then you can move on to other things. And then another metric is that not only the appointments that are scheduled, but the percent of PCP appointments at 14 days and at 30 days. So not only was the appointment kept, was the appointment made, but was the appointment kept. Third, the percent of post-hospital services that are scheduled if needed, and the percent best time for appointments clarified. So how often at the beginning when the appointments are made were the best time for the appointments clarified. And at the bottom here, we put down some of the data sources that could be used to create those metrics. So it could be the 30-day post-discharge follow-up survey, which you could send to patients to identify whether they saw PCPs, or you could look at in your system, look at the database to see how many people made appointments. You could look at your electronic medical record. The discharge educator workbook could be a data source. The RED workstation, as Marcus talked about before, is now able to print some very important process outcomes automatically, which is very, very helpful, and a report from the discharge educator about that patient. So number two, discuss the tests and studies completed and who will follow up on the results. And one reasonable metric is the information listed in the after-hospital care plan? Were you able to identify the tests that are pending, and was it listed in the after-hospital care plan? And third, is this information reviewed with the patient to discuss this with the PCP at the follow-up appointment? And the RED workbook would identify whether or not there were pending tests that were identified. The workstation will identify whether or not the pending tests are listed in the after-hospital care plan, and then some report or surveys of patients later will tell us whether or not that information was discussed at subsequent follow-up appointments. For number three, organize post-discharge services. Reasonable metrics might be the percent of patients who provide percent provide patient with contact information for those services. So on the after-hospital care plan, if oxygen company is coming, what percent of the time is that listed in the after-hospital care plan? And if it is, then how often is the information necessary to be sure that it happens appropriately contained in the after-hospital care plan? And secondly, the percent with arrangements being made for necessary services and equipment, as indicated by the hospital progress notes, I think might be a little bit difficult if you're going, if you're looking at progress notes to identify what services ought to be delivered or not, but is possible certainly to measure. So these are some decisions that your implementation team can work through about what are the initial metrics that you're going to use to measure both process and outcomes. Number 4 is confirm the medication plan. The percent of patients were reviewed, the medications were reviewed, and make sure that the patient knows what they are. And the percent of after-hospital care plans with the medications listed. And we were not always able to reconcile medications. So does the discharge educator workbook have information about the medications? Are they on the after-hospital care plan? That could be a report directly from the software, etc. Number 5, reconcile the discharge plan with national guidelines. Simply is the percent of after-hospital care plans that are reconciled with national guidelines. And that could be a separate data sheet that the discharge educators somehow check off that they reviewed, if for heart failure patients, that they reviewed the key indicators for the heart failure pathway and whether or not they're included in the discharge plan or not. Number 6, give a written discharge plan at the time of discharge. So this is the percent of after-hospital plans that are given to patients, and do those after-hospital care plans include the diagnosis, the medication instructions, the follow-up appointments with the contact information, any pending test results, and tests that require follow-up. And again, this is collected from both the workbook and the workstation, as Marcus again presented, could automatically provide you with the percent of the time that information is included in the after-hospital care plan so that you can track over time the quality of the after-hospital care plans. And that's a great advance. Number 7 is to educate the patients about their diagnosis throughout the hospital stay. A reasonable metric is the percent of the RED patients getting education about their diagnosis as documented by the discharge educators, or the percent of RED patients who go home with an after-hospital care plan with information about their diagnosis in it, and that would simply be recorded in the software or in the workbook. Number 8, assess the degree of patient understanding. Ask the patient to explain the discharge plan. And so from the nurses reporting the percent of time that they use TeachBack, the metric would be the percent of RED patients who had received the TeachBack technique, the percent of patients who are able to understand their medications appointments, able to understand the plan prior to going home, and the percent use of professional interpreters as needed. Might be a little bit tricky to calculate, but is a very important metric in terms of are we able to educate all of our patients before they go home. Number 9, review the appropriate steps for what to do if a problem arises. Reasonable metrics may include the percent of RED patients educated about what to do, the percent of after-hospital care plans with the contact information for the discharge educator, and information about the primary care provider that's written on the after-hospital care plan. And if the software is not able to do that, then I'm sure that it could easily report on those metrics. And number 10, expedite transmission of the discharge summary to the PCP. So the metric simply is the percent of after-hospital care plans or clinical summaries that go to the PCP within 24 hours after discharge and by 48 hours after discharge, which I think is a reasonable metric, a very reasonable metric to show success of being able to complete that component. And then finally, provide telephone reinforcement of the discharge plan after discharge, the percent within 72 hours after discharge who are reached by phone, the percent of calls completed with review of the medications, percent with review of the follow-up appointments and actions to resolve the problems, and then data from some of the phone call slides. So there some data from the discharge educator help line. So this is when the discharge educators would leave their phone numbers to call on the after hospital care plan. How many patients? Some patients would call back, like the phone call logging system that you talked about. So the discharge educator could keep a log of those calls from patients who call to see what the quality of the information is and the number of patients who are calling. They could monitor the post-discharge processes with the discharge educator. Call logs, that all post-discharge communication with the patients, pharmacies, physicians, etc. can be documented and tracked through the workstation. The outcomes measured by the call logs can include adherence to the after-hospital care plan, post-discharge unanticipated problems, need for telephonic interpreter services, post-discharge areas of confusion or uncertainty, and adequacy of social support services, and a monthly review to determine the need for focused feedback of supervision, basically, of the discharge educator or other personnel who are handling those calls. Patient surveys post-discharge are also a good way to collect data about the quality of the hospital discharge. That the HCAHPS and Press-Ganey reports that all hospitals get are helpful, but specific patient surveys regarding the discharge experience might be helpful for you as you monitor your implementation of the program. So typically, mailed surveys have a very low response rate. If possible, telephone surveys 30 days post-discharge on a high proportion of patients in the first 4 months might give you some information about how successful the program is from the patient point of view. That we at 30 days ask questions like, how prepared were you for discharge? How prepared were you to take your medications? How comfortable were you, etc. And have scales for what we think is a reasonable number in terms of being prepared at the time of discharge by patient report at the 30-day survey. The outcomes that can be measured by the patient surveys include the rate of PCP appointment attendance, the knowledge of discharge diagnosis, the CTM3 questions, which is the Care Transitions Management questions, which are 3 questions, the Red Discharge Preparedness questions that I just mentioned, and HCAHPS Literacy Selected questions. And in our tool book, under this section, all those things are listed there, and so that you have examples of the kinds of questions that can be given at the 30-day survey and at the phone call if you choose to do it that way. Yes.
G. Lee. G. Lee's from Quality Management. She's over patient satisfaction.
We do have restrictions, and right now we can get OMB approval, but they have to send it in batches, and the timeline will be, I don't know what, it could be several months, but we could ask open-ended questions, but we can't do any scales. That's our...
Because of regulations from Office of Management and Budget.
Yeah, they have regulations on how many minutes a veteran can be surveyed nationally, and so they're very restricted on questions, and then they're engaging it to ask questions that they're being surveyed.
Yeah, so that might make it harder for you. HCAHP questions are sent out by the hospitals? Yeah. Okay.
By central office.
And Press-Ganey, is that something that's used in VA?
No. VA does not use Press-Ganey.
Yeah.
They have their own survey.
So the HCAHP questions are good, and there's specific transitions questions on there that you could track over time and compare those patients who received Project Red versus those that didn't to see if there's a spread in terms of those two, and that would be an interesting outcome to follow.
The other limitation for us is it's not broken down, and so only by medical, surgical, and then psychiatry. So if we were to break, certain wards doing Project Red, we wouldn't be able to know because it's an overall score.
I see.
But
so
that's also being looked into right now.
So there's no personal identifiers necessarily on that?
There's a lot of work going on right now because of the push for magnet throughout the VA at getting it down to the unit level. So there's hope to come, I think, in the future for that.
Yeah. So those are all really good points. So that you are kind of left with all the process measures that we talked about, and there's a lot of things to measure, and that the survey data sounds like it's difficult in this environment, but that's okay. In terms of monitoring major outcomes, the process is just the process. The process, if you do the process well, then hopefully the major outcomes are improved, and the rates of hospital reutilization. And there are 4 common measures of 30-day hospital utilizations. So there's readmissions, more than 24 hours, observations less than 24 hours, emergency department visits, and urgent care visits. And it's probably reasonable to separate those out, because it could be that an intervention like Project Greg could impact one and not the others necessarily. There's also a lot of talk at CMS. I was on a panel that was talking about unintended consequences of decreasing payments for 30-day, using 30-day readmission as the metric. And people are worried about what's going to happen to the 31-day readmission rate. What's going to happen to the observation rates? Those things are going to go way up. Or what's going to happen to patients who are in the emergency room for a whole long time and not admitted because they've been in the hospital the week before, and the hospitals aren't going to get paid for that. And those sort of unintended consequences are real. Yeah.
It seems like a unique situation where the process measures are actually more difficult to obtain than the outcome measures.
Yeah, that's probably true.
And I'm just wondering how you all have, because I have to say, as you were running through those process measures, it was kind of intimidating.
Yeah.
I wonder how you think about the give and take of focusing on a subset of those and the outcome measures. Which
I certainly would recommend picking 1 or 2. Probably there may be 50 that I listed. Pick 1 or 2, the important things, like, was an after hospital care plan produced and given to the patient?
We should have started off with that comment. It was like, oh my God, 50.
Yeah. So I pick 1 or 2 of the things that are really important. And then the quality of the after hospital care plan now can be generated from the software directly. And that's probably what I would do. And then go from there. You might also want to, in terms of major outcome assessment, is to stratify some of those outcomes. And ways that the outcomes can be stratified could be by diagnoses or comorbidities. Of course, the congestive heart failure and pneumonia and heart attack and COPD and other things like that have different readmission rates, and to look at how each of them is changing might be important. It also might be important to stratify your outcomes by the physician or the physician group or by service. And it could be that some practitioners or groups of practitioners are associated with higher or lower readmission rates than others. Also might be important to stratify outcomes by the admission source or the readmission source. Did they come from nursing homes or did they come from home, or to determine if there are places where patients are most often being readmitted from. And also in different time frames, such as 7, 30, 60, and 90 days. And that there's a concept now that there's the shorter, that there's the early 30-day readmissions and the late 30-day readmissions. And the etiology of those might be slightly different, and that the first is really more of an indicator on the quality of the hospital discharge. The second is, did they get into ongoing care and the quality of the ongoing care after that. And then finally, rates by sociodemographics. So you might want to stratify by ethnicity, maybe by neighborhood, by language preference, or by insurer type, to ensure that appropriate use of benefits and identify the ways patients may be guided to optimize their benefits. And then also in terms of the discharge educator supervision, it may be reasonable that the implementation team identify ways that the discharge educators are supervised, and that weekly meetings with them might be a reasonable thing to do to ensure communication among the team, to learn about any difficulties they're having or resistance they may be facing in fulfilling their agenda vis-a-vis the other hospital team members and be sure that they're getting adequate support to do their job well. And conducting chart reviews for measures and root cause analysis we've found to be very important, and that we are now doing this on our service, and that you learn a lot from unexpected readmissions. The chart review and discussion with providers for the sample of patients who return to the hospital within 30 days to evaluate potentially avoidable events, to ensure that the various components of the project are happening, and to help promote fidelity and to identify areas for improvement. And now we're not doing it monthly, but really in real time, that we have someone identifying all patients who are patients who have been readmitted within 30 days, and they're flagged on the board on the ward so that everybody's aware that that patient is a readmission, and that we have people who are responsible for reviewing all readmissions in a root cause analysis kind of way to identify, is there something that we could have done differently for this patient in terms of the discharge plan or in connecting to the community-based services that could have prevented this readmission. And we learn a lot about what we can do better. And I think that that's an important part too of sort of driving the rates down. So that's the end of our sort of formal comments. We have time at the end that David is going to do some wrap up, and we can participate in that. But I just want to thank you all. I hope that we sort of encouraged discussion, presented new ideas, facilitated you teaching each other about all the great things that you're doing, and that we taught each other a little bit about what the future looks like in terms of healthcare reform and hospital transitions and care. So we now have a little bit of time for back and forth, David, if you want to do that in terms of wrap up.